Great. I'm sure more people will join in the next few minutes, but in the interest of time, I will make a start on things. Thank you all so much for joining. My name is Angelique Hall, and I'm the Network Coordinator for the Violence, Abuse and Mental Health Network. Welcome everyone today on our webinar on domestic abuse and mental health. Please feel free to introduce yourselves in the chat. It will be really nice to see who we've got dialing in today. And we're delighted to be collaborating with our colleagues from the Connect Centre. Before I hand over to them, I'm just going to briefly tell you a bit about the Violence, Abuse and Mental Health Network in case you're not familiar with us. We're a research network of over 1,000 individuals and organisations, from academics to policymakers, people from the third sector and people with lived experience. We aim to bring together people from different sectors and disciplines to understand, prevent and reduce the impact of violence and abuse on mental health. And we run a range of activities, including hosting webinars like these, funding research, providing support for early career researchers and creating resources. I'm going to leave our website in the chat, where you can also sign up to our monthly newsletter, and we share relevant resources and information there. And I'll be live tweeting today from our Twitter account throughout the webinar, so feel free to follow along. Our account is @VAMHN. And with that, I'll say thank you all again for joining and pass over to Nikki Stanley, who will introduce our speakers today. Over to you, Nikki.
Hi, everyone. Hi, great to be here today. And thanks to the network for hosting us. I'm Nikki Stanley. I'm co-director of the Connect Centre for International Research on Interpersonal Violence and Harm. And we're based at the University of Central Lancashire. I'm going to take a few moments to tell you a little bit about our work, and then I'll introduce our three speakers for today. We've got three great papers for you today, and I think everyone's going to find it a really interesting event. So here we are. You're all at the Connect Centre in a virtual way. Next slide, please. So just briefly what we do, there we all are at various events. You can see us all, the picture of us all standing in front of a pond. That was a writing weekend we did. There's a few of us at an international conference, and there's all our lovely PhD students at the bottom. So our research focuses on understanding, preventing, and we're doing quite a lot of work on prevention at the moment, but also on responding to interpersonal violence. And we define this as violence between individuals and include all forms of sexual and domestic violence and abuse to adults, and violence, abuse and neglect of children. And as well as conducting and disseminating research, we supervise PhD students and contribute to knowledge exchange and teaching, both for students and practitioners in a whole range of settings. Next slide, please, Helen. Okay, and we're called the Connect Centre because we like to make connections, and we feel our work is to challenge fragmented thinking about violence and abuse in order to develop new ways of thinking about prevention. We bring together research on gendered violence to adults and to children and young people. We do research on overlapping and polyvictimization experiences, and we're interested in harm and abuse across the life course. We're interested on prevention in diverse settings. So we've got a big study just completing that's been done in schools. Christine, who's the co-director with me, has done a lot of work recently on sport, football in particular, and we work in social care and in health settings. And we're interested in research on both victims and perpetrators, including young people who harm others. Next slide. Okay, so here we all are. Liz, we don't seem to have a picture of you, but you're going to see lots of Liz later on. She's very lovely, so you will get to glimpse her. And I think I've got one more slide just to introduce. Oh no, we've got a slide here about some of our recent publications. We've got two big reports coming out in October. Our evaluation of the roadmap intervention, which has been a very innovative programme of domestic abuse services for women and girls, and our evaluation of the NSPCC's Speak Out, Stay Safe programme, which is a major prevention programme delivered in primary schools across the UK. So look out for those on our website and other websites as well. And we also, Christine's been very busy with special issues, as well as recently co-editing one on digital technologies and gender-based violence for the Journal of Gender-Based Violence. She's going to be involved in editing one for Child Abuse Review on young people's friendships and safeguarding. Are we going to make all these slides available to people? Do you know, Helen? Helen's nodding furiously. So
yes, we are. Yes.
You're going to be able to pick up on these links. Maybe we can pop them in the chat too.
Yeah.
Next slide, please. Okay, so you've got 3 great papers today. First of all, Helen Richardson Foster is going to be talking about mental health outcomes for survivors of domestic abuse, drawing on this major evaluation of the roadmap services that we've just completed. Christine Barter is going to be talking about intimate partner violence and abuse and the impact on depressive symptoms in young adults with her colleague Laura Howe from Bristol Medical School. And Liz Bates is going to be talking about mental health dimensions in domestic homicide. So we've got a full morning. We'll try and stop after each paper and make space for a couple of questions, and hopefully there'll be time for more questions at the end. I think you'll have your mics off while the speakers are talking, but if you post your questions in the Q&A, we'll pick them up at the end of papers. Okay, so Helen, you're our first speaker and it's over to you.
Lovely. Thanks, Nikki. Bear with me 1 second while I just get my presentation to share. So, is that looking okay to everybody? I'll assume so. Yeah, thanks. Okay, yes, thanks, Nikki. So I'm going to be talking about the mental health outcomes in particular for survivors, which is findings from an evaluation of a community-based domestic abuse service that I'll tell you more about. Nikki was our PI on the evaluation, the roadmap evaluation, and I also worked closely with Professor Christine Barter, who led this side of the work. So just to acknowledge them from the start. So yeah, what I'll tell you about this morning, give you a brief introduction to the evaluation and the intervention. I'll talk a little bit about the methods that we use for this side of it and who used the service, then focusing on the mental health outcomes for the service users and what we found, and finally just concluding with a little think about what were the facilitators and some of the key service elements that we noted here. So the roadmap evaluation, as Nikki said, it was a big study, and I'm going to be talking about a part of a wider evaluation. The roadmap evaluation looked at services delivered by Women's Aid and Safe Lives in 5 areas of England. This was funded through the big lottery Violence Against Women and Girls stream, and the evaluation was led by Nikki at UCLan, and it also involved the universities you can see there, Bangor, Manchester Metropolitan and UEL, and we also worked, we co-produced our evaluation with survivor researchers, and we had 2 PhD students. So it's been a big undertaking, which began in 2016, and we've just concluding it this summer, and the report is about to be launched. So as I say, I'm going to be focusing on the Safe Lives services, which were commissioned in 2 areas of England. As I'm sure most of you are aware, Safe Lives is a UK-wide charity which is working to end domestic abuse, and it works in collaboration with other organisations to deliver training and to develop new models of intervention. So the funding that they received was to pilot the delivery of whole family services. And so this big diagram here shows the Safe Lives Commission services. They were delivered in one area by a group, a consortium of 3 organisations, and in the other by one charity. And it comprised these 5 sort of main elements with a couple underneath. So I'll just go through it to explain what was offered. So there was community ID for work, which was individual strengths-based support provided on a one-to-one basis. There was also a complex needs IDFA, who provided more customised and personal support for people with multiple or complex different needs. Then there was a whole stream of step down and recovery work, mostly in group work, but it was a programme, designed for survivors' recovery and through to peer support work. And there was also a significant element of children and young people's work that included individual and group work for children aged from 4 to 17. There was also support for parents, parenting support, support for adolescent to parent violence, a whole range of interventions there. And finally, the engaged stream was specialist support for perpetrators in families who wanted to stay together. So here, this comprised one-to-one group work for the perpetrator, for the survivor, and there was specialist CYP workers as well, so working with the whole family. On the bottom, you can see there was also a skills enhancer and peer mentoring and support in both areas. And there was also obviously a project manager. And the Safe Life whole picture approach, it was an integrated domestic abuse programme tailored at the whole family. And the idea was that survivors and children could have a range of services and move between different interventions on their way to recovery. So if I talk about how we evaluated that, so the evaluation was large, and I'm just going to hone in on some of the bits that pertain to the Safe Lives Commission services. Hang on, I'll come to that. Sorry, I'll just tell you a little bit actually about who used the service. So in terms of the service users in the evaluation period, this data here is taken from the service user data. And I can tell you that we had 481 female survivors use the service in the time period of just over 2 years. The majority were aged between 26 and 45, mostly white and heterosexual. 84% had at least one child, and 23% had a disability, of which 12% were identified with a mental health need. There were 270 children using the service and 56 perpetrators, and again, similar background in terms of ethnicity there. And the majority of the children using the services were aged under 10, 66% of service user children were aged 4 to 10 years. So the ethnicity and background were similar to the wider area, and in terms of the demographics of the people who participated in the evaluation, they were similar to what we know about the service users. So I won't go into the same details there. What else do I need to tell you about that? Yeah, I think that's probably got all that covered those. So let me move now, sorry, to the evaluation methods and the data collected for the Safe Lives services. So yeah, as I say, we've had a wide range of methods. I'm going to be talking today mostly about the survivor outcome measures, which is the top line, and the results from the individual interviews we conducted with survivors. So you can see in terms of the outcome measures, we had 188 completed at time 1, which was at baseline. Then at 12 weeks later, time 2, we had 88 completed, both at time 1 and time 2, and 56 from time 1 to time 3. We also did ask people to complete them at the end, but we did see a significant sort of attrition and completion, and also being able to compare from time 1 to time 2. The outcome measures I'll tell you more about as we go through, but the outcome measure included measures of safety, coping and confidence, well-being and health, using some standardised scales and some that we adapted. And then we also conducted individual interviews, focus groups, case studies, and staff interviews and surveys. So let me tell you now about some of the key findings relating to survivors' mental health. First one from the outcome measure is looking at their safety. So when we come to the stars there show which this was the 6-item scale, and we can see the stars indicate which ones were statistically significant using the Wilcoxon signed ranks test. So we can see that from time 1 to time 2, there was change in all items, apart from people saying, I know where I can get help when I need it, but actually the levels there were already high at baseline, with 3/4 saying this was the case often or all of the time. And this was reflected in the interviews that we conducted with survivors. For example, this woman saying, you know, she felt she had a thing with not being able to lock her door. She saw it as her way out rather than somebody's way in. And every week she, the IDFA, would ask, have I been able to do it? And she gradually got to the point where she was locking her door all the time. So there were some improvements in people feeling safe. Another measure we used was of coping and confidence. This was an 11-point scale using the Viva scale from Kelly et al. In 2014. So that's the measure there over on the left, and on the right, these are the items where we found a significant change from time 1 to time 2, and then from time 1 to time 3 at 6 months. Different measures were significant at both time points, but overall, all of that, you know, there were some changes in coping and confidence, and feeling in control, feeling able to speak to people about their experiences of abuse, wanted to, recognizing if other people has been abusive. And then this is also shown in the interviews. I love this person who was saying, you know, just feeling a completely different person, really positive and confident, even started her own business. And the other quote is from somebody saying how, and I think this sort of shows the multifaceted element of the intervention. So she says, because the support I received and the support the boys received, her sons, I have more knowledge now. Before, I just didn't have that understanding, and I did the course. And that impact was on the boys as well. So I can see that more clearly. It's easier to deal with. So she had support for herself, but also support for the children, and the increased understanding and awareness of what was happening with domestic abuse and the impact it had on them as a family, all was combining for feeling, you know, increased able to deal with parenting and dealing with life. So, and another final one I want to mention, I won't tell you about the health outcomes today, I'll tell you about the wellbeing outcomes. So these were the wellbeing reported by service users. We used the short Warwick Edinburgh mental wellbeing scale, that is the short one, which has just 7 items. And what you can do with the 7 items is use the cut scores that is given with the scales. And we can see here the changes from time 1 to time 2 when we divide people into categories of probable depression, average mental wellbeing, and high mental wellbeing. And so at time 2, there was an increase in people's average mental wellbeing, but not in high mental wellbeing. However, when we look at the mean figures, you can see that overall there was an increase by just over 1, from 21.6 mean score to 22.7. This is still lower than the UK women's national mean for UK women, which is 23.6. So women at T2 at 12 weeks there were some improvements, but there was still poorer than average mental health in our survivors. But we'd also asked the people every time after the time 2 onwards if they'd experienced change as a result of using the service. And this chart here shows that of the, let me just check, 80 survivors who answered this question, 92% yes, I have experienced change as a result of using the service. And you can see that mostly or partly due to the service was the main answers. Only 7% said that improvements were due to other things. So there's a lot of attribution of positive change through the intervention. And then just because we're focusing on mental health and well-being today, I wanted to show you what happened from time 1 to time 3, so around 6 months. So the same bar chart again, and we can see here that for the 54 people who completed the outcome measure at this point, there was a greater increase in those using the cut scores who were in the average or high mental well-being in the orange there. And the mean short Warwick Edinburgh mental well-being score increased by 2.54 by T3, which was approaching the UK national mean for women, and that was a statistically significant increase. And again, to look at that attribution pie chart, we can see here, oh, I'm missing my mostly due to other things, but you can see that in about half it was mostly due to the service, on 30% partly due to the service, and 13% said their improvements was entirely due to the service. So again, lots of attribution to the benefit of the service. And this was reflected in the survivors' interviews that we conducted. Let me just get my notes and talk you through these ones. So some of us told us about how their mental health had improved over time, such as the one on the left, where this person's saying they weren't waking up every morning feeling like they're going to be sick and feeling fearful. Some described the techniques and the ideas and the methods that have been given to them by the workers through the group, through the individual support, techniques to help focus on their well-being. This woman says that they also help me have a focus on where I want to be and where I want to go, so planning ahead for the future. The dark purple quote, I think is interesting. This person saying that the worker talked her through what trauma is, what our brains are, what we're doing when we're in trauma, why our bodies react the way they do to it. So for some, that understanding of trauma and trauma's impact was really key in helping recovery and helping understand their well-being. And for some, as we've seen in the data, there was still a low level of mental health and some way to go on their journey to recovery. And also I should say that we were speaking to people sometimes who were, 3-6 months into what could be over a year of using the service. And so this survivor who I spoke to, who was using the complex needs adverse support service, was still very much in the midst of a very difficult situation, was saying, well, at the moment, today my bar was on a 6, last week it was on a 5, but it's going up, and next week I could go back down again. So obviously it's not a linear path, and for some, work was very much still underway with them. And I wanted to say a little bit about what we've thought in terms of the particular service elements that contribute to improvements in mental well-being and what seemed to be working well for the survivors from the service. The first one being the individual IDVA support. So just some quotes here to sort of illustrate that and the complex and the work that was done. So this quote here, the mum's talking about the work that was taking place with her in terms of family courts, helping her keep her mental state stable, helping her with her anxiety that was related to that. And again, this understanding of the impacts of domestic abuse and emotional abuse, and recognising and acknowledging what had happened to her. So getting that on an individual basis from the support sessions. And this mum saying, just having that contact, someone to talk to, making me see that it wasn't right and give me some pointers, different ways to handle things for myself, and encourage me to have time for me, which is difficult when you're a mum of 4 on your own. So IDVA individual support was really valued, but there were other key aspects of this whole family multifaceted intervention. And another big one was the group work and support. And so we did conduct focus groups with some of the groups that took place in 2020, and we did those on Zoom. And some of the people that we spoke to said I think the key thing here is in that pink quote where people are saying, I'm not on my own. And it's just so empowering having other women who've been through it. And she talked about the WhatsApp group that have been set up to keep people in contact and still manage to see each other even in the pandemic. The blue quote there, people saying, you know, I like that it was a group environment. Again, people saying, you know, talk about what the types of abuse are, how it makes you feel, where you feel that physically in your body, and that it's not okay. And when your self-esteem is on the floor, you don't know any different. So the value of having group people to affirm and, you know, confirm what's been going on. And the dark purple quote here I included because I thought it just really highlights the high levels of isolation and loneliness that some of the survivors told us about. I was lost because I was very lonely. I had no friends, no contact with neighbours, with my colleagues. I was really isolated and I needed the group work just to feel part of society. So for some, it really was a lifeline and a step towards rebuilding their life and getting back out there after being, you know, significantly isolated from their by their partner and by their experiences from being able to join in with things. So it's a really important first step. Yeah, and I like this one. This woman saying, you're free to speak and you have hope that things can get better, just as it was with them. Nearly there, Nikki. So yeah, so the group work was a key element. And another thing I just wanted to mention was that there was some specific counselling provided. The interventions recognise the importance of therapeutic support for survivors and trialled the use of some electronic and web-based methods, and also had funding available for one-to-one therapy. And this person, you know, really valued that, but was concerned about the time-limited nature of it. This person, they're saying that it's like, then what would happen? And this person had had so much support from the service, including being able to access counselling when things had got really difficult on the course and she needed to have a break, and she could access one-to-one support, which was valued. And that one there was from somebody talking about the life-changing impact of EMDR therapy that had meant she was feeling so much better and hadn't had triggers impacting her since she started the 8-week sessions. So just to conclude, thinking about some of the facilitators that we identified to delivery that I've already mentioned really, but the variety of interventions that were available to meet individual needs was really valued by survivors, both the individual and group work options, and most people used at least 2 different types of services. And having this variety of interventions, survivors valued being listened to and understood, and work that matched their pace, and being able to choose from a suite of services that they needed at the right time. So that quote there saying, you know, it was very much led by me and what I needed. And combined with the fact that there was support available for children, that was really important for many of the survivors who were parents, and that the team could work together and sing off the same hymn sheet, so to speak, which was really valued. So you weren't having to tell your story multiple times to different intervention providers. And then finally, just some conclusions and recommendations. So as I said, we've seen increased confidence, improvements in mental well-being, but the survivors did have low levels of mental health. And for work with all survivors, especially those with complex needs, with mental health needs to be effective, links between DVA and mental health services and other health services need to be strengthened. And that's something that's available in our wider evaluation report, which you can read. As I mentioned, value of survivor-centred services and a flexible service response to changing needs and support with parenting group work. And this kind of work requires a substantial resource, integration of staff roles and clear service remits. Right, that's me all done. As I will, thank you, just to say a final thank you to Safe Lives and Women's AIDS Commission in the evaluation and all the survivors, children and staff and experts with by lived experience who contributed to the study. And the full report will be available very soon. We can give you the link to read more about it. Thank you.
Thanks, Helen. That was great. Some comments saying it sounds like a really great service. Amanda noted how difficult it is as a survivor of domestic abuse to also access a service for your children. And I guess one very particular feature of this service was its integrated approach, which meant that the same service was providing a range of services for survivors themselves, but also both individual and group work for children as appropriate. An interesting link from Davina. We do have one question from Nikki Graham Kevin, who says, what about male survivors and the gender spread of perpetrators? Do you want to answer that, Helen?
Yes, so the survivors, because it was funded through the Big Lottery Violence Against Women and Girls stream, we only interviewed and looked at the experience of female survivors. I think there was a very small number of male survivors who did use the service in the areas. The perpetrators were all male, I think, from memory. I can double check that, but
I think there were 2 female perpetrators
in
the service data, but that was just 2 in a very large number. So
yes,
this was funded under the Big Lotteries Women and Girls program, which meant that the focus was mainly on female survivors. But I think there were a small number of male survivors who contacted the service.
Yeah.
Let's see if there's anything else in the Q&A to pick up at the moment, but hopefully...
Nice comments about fantastic outcomes. Yeah, it was nice to see. Yeah.
Okay, well, let's in that case move on to our next paper from Christine and Laura. Hi, Christine, I can see you now. Is Laura coming in later?
I do hope not. I hope she's going to be there. Hi, Laura.
I'm here.
Laura.
I'll switch my camera off.
Welcome. Welcome. I'll let you introduce your paper.
Okay, thanks, Nikki. So I'll just introduce myself. Laura, do you want to turn your camera and sound on just so you can introduce yourself? I'm Christine Barter. I'm Professor of Interpersonal Violence Prevention at the Connect Centre and co-director of the Connect Centre. And Laura, do you want to?
Yeah, I'm Laura Howe and I'm a Professor of Epidemiology and Medical Statistics at the University of Bristol.
Thanks, Laura. So I'm going to start, then I'm going to hand over to Laura for the analysis and findings, and then it's going to come back to me for implications. So the research we're going to talk about today is called Young Adult Relationships and Health, YARA for short. So can we have the next slide, Helen, please? And YARA is funded through the MRC, and the presentation today is based on a paper where the link is below. It's going through review at the moment, but you can actually look at it at preprint at that link there. And I should just mention Annie Herbert, who is our fantastic researcher, and very happily for her, she's on maternity leave with a lovely, healthy, bouncy baby. So Laura and I are stepping in to do the presentation today. So YARA, oh, and also I should say that Jean is PI on the study at Bristol, and it's a collaborative study between Bristol and the Connect Centre at UCLan. So the aim of the study, the first aim is to examine data on IPVA experiences in 21-year-olds, and this had already been collected as part of the VAMHN longitudinal study of parents and children, ALSPAC. This is also known as Children of the 90s study. So this is a birth cohort study. VAMHN doesn't exist anymore, but it's in the southwest surrounding area around Bristol. And we're also, alongside doing the quantitative analysis, undertaking interviews with young adults. We're using life qualitative course interviews to explore their experiences of IPVA and also other childhood experiences, including harm and trauma, and looking at the relationship they bring to this in between their experiences of harm and also their health, and also looking at turning points. So we are hoping that these two types of analysis complement each other and that they provide a uniquely detailed investigation of the causes and health consequences of IPVA in young adults. And the reason we wanted to do the study was to inform policy and also the design of public health and clinical interventions for young people exposed to IPVA in adolescence and also in early adult relationships. Thanks, Helen. So let's have a little look about the background of why the study is necessary. So there are a number of previous studies which look at the association between IPVA and depression. However, we don't know from these studies if this is a causal relationship or if this association is explained by wider confounding factors, for example, previous experience of trauma or harm. So there are a few longitudinal evidence studies which do examine the risk of depression following IPVA victimisation, but none of these are based in the UK. There's some international longitudinal evidence. This mainly involves younger adolescent cohorts, and some of these do suggest an increase in depression following IPVA victimisation, and this includes after adjusting for baseline depression. However, only one study we've been able to find is able to adjust for other potentially confounding factors, for example, age, socioeconomic status, childhood maltreatment. And this study did show a small increase in mean depression scores 5 years following psychological or physical IPVA victimisation. They didn't look at sexual victimisation in that study. However, we felt the range of factors adjusted for in this analysis would not really be able to fully capture the larger range of factors that can influence both IPVA and depression, and that's why our study, I think, fills a unique gap in our understanding. So our concern remains to understand the extent to which these associations are causal. The reason why this is so important is that because it has implications for interventions, and if associations are not causal, this does suggest that there's a greater emphasis is needed on earlier stages of the life course to prevent adult mental health problems. Thanks, Helen. So a little bit background for the analysis for this presentation. We're going to only use data from the ALSPAC population-based cohort today. So around 14,500 pregnant women living in the Avon area with delivery dates 1991 to 1992 were asked to take part, and 3/4 of those who were eligible agreed. Those children are now young adults, and for our study, 3,280 participants answered questions on psychological, physical and sexual IPVA at the age of 21. And we asked them to report on their experiences prior to turning 18 and between the ages of 18 and 21. So our questions, our IPVA questions, were based on previous questionnaires I had developed and used with colleagues in the past, and also Provide questionnaire. And the questionnaire in the ALSPAC database has been independently validated as well. So in the box there, the purple box, I put some examples of behaviours in relation to coercive control that we asked participants to answer, and they were asked to respond to all the questions: coercive control, physical or sexual forms of abuse, never, once, a few times, often. So we're only reporting on victimisation today, but we also looked at perpetration as well. So one of the issues we have is that we need to control for causation to ensure that we're not confounding IPVA experiences and depression. So for those who experienced IPVA before the age of 18, we also have our baseline depression data at that stage. And we don't know when the IPV took place. So actually we've had to remove 487 who experienced abuse before 18. And that leaves us for this analysis with 2,793 participants. Lovely, thanks, Helen. So the table you can see there, it shows the prevalence rates for different forms of IPVA we found within our data for males and females. And it's important to note that the number of women responding to this section of the questionnaire is substantially higher compared to the number of male respondents. But overall, just over a quarter of young women and 1/5 of young men experience some form of IPVA victimisation, although proportionally more women experience greater levels of sexual violence. Thanks, Helen. So looking at our depressive symptoms, these were captured at age 23 via the Moods and Feelings questionnaire. And this questionnaire asks 13 questions about depressive symptoms in the last 2 weeks. And responses are not true, somewhat true, or true. So that's the measure post-IPVA that we're using to measure our depressive symptoms. Thank you, Helen. So moving on to look at our variables. Overall, we have in the analysis 15 different variables. And if we actually break down the adverse childhood experiences one at the bottom, that increases to the individual components, that increases our variables to 24. And these were chosen based on previous literature as the known risks of IPVA and also known risks for depression. I'm now going to hand over to my colleague Laura, who will talk us through the analysis and findings. Thanks, Laura.
Thanks, Christine. Can I have the next slide, please, Helen? Thanks very much. Okay, so this table is just going to talk us through some descriptive findings. So at the top, we've got the women and 1,300 who were not exposed to IPV in young adult relationships and just over 400 who were. Then we've got this measure of depressive symptoms at age 23, and we're using this as a continuous score of symptoms. So the average score of depressive symptoms in women who didn't experience IPV was 5, and in those who did, 6.3. So you can see that the depressive symptoms are higher in the women who experienced IPVA compared with those who didn't. The same was true for men at the bottom half of the table. So a score of 4.7 on average for men who didn't experience IPVA and 5.6 for men who did experience IPVA. Then on the right-hand side of the table, so our main analysis is sticking to this continuous measure of symptoms of depression. But most of the previous literature has looked at a binary measure of depression, yes, no. So to be able to compare with that literature, we've used our score to create this binary measure of depression. And there we can see that in women, IPVA exposure is associated with a 2-fold risk of depression, and in men with a 40% increase in the risk of depression. So a stronger relationship in women than in men. And that odds ratio of 2, so a doubling of the risk of depression, is broadly consistent with most of the literature in this field. So just kind of giving a bit of validity to the fact that our sample is not too dissimilar to other general population studies that have taken place on this topic. Next slide, please, Helen. Okay, so then a little bit more detail of the analysis. What we wanted to do was build up our model to adjust for different factors that could be muddying the water in the association between IPVA and depressive symptoms. So here we've got a measure of the percentage change in depressive symptoms that's associated with IPVA. So at the top there, our crude means we haven't adjusted for anything. So that's our basic model. And we can see that in women, IPVA is associated with 36% higher depressive symptoms compared with those who didn't experience IPVA. Then the bottom of this table works through a series of analyses that try and get at whether that big list of factors that Christine showed you is confounding or biasing that association. So in women, we can get that 36% down to about a 20% increase in the risk in depressive symptoms once we take account of all that set of measured factors that Christine mentioned. In men, adjusting for those variables does a lot more to that association. So in men, we go from 20% increased depressive symptoms when we don't adjust to anything, reducing to about a 5% increased depressive symptoms when we take all of those factors into account. Next slide, please, Helen. But then what we really wanted to do, because we know that even though we've got this huge list of things that we've adjusted for, prior adverse childhood experiences, socioeconomic factors, and other things that we know are going to be associated both with the risk of depressive symptoms and with the risk of experiencing IPVA, What we really wanted to do here was make use of the longitudinal nature of this data to say, we know what happens, what the depressive symptoms were in these people before they were exposed to IPVA and after. So we can say, did that exposure to IPVA lead to a change in their depressive symptoms? So here on the left, we've got the men, and on the right, we've got the women. And you can see their depressive symptom score at age 16, so before the IPVA was experienced. And then on the right-hand side, at age 23, after the IPVA was experienced. And those black dotted lines show you the time period in which our IPVA measure is capturing, so 18 to 21 years. So for both the women and the men here, what you can see is that the group who were exposed to IPVA, the blue lines, were really different to the group who were not exposed to IPVA, the red lines, at age 16, before the IPVA occurred. And to kind of make this study design work, we've had to remove the people who were also exposed to IPVA in pre-18-year relationships from our analysis. So these people, the blue line, they were only exposed to IPVA between the ages of 18 to 21. And that difference in depressive symptoms is really evident at age 16, before the IPVA took place, and it doesn't widen by age 23. So if the exposure to IPVA between 18 to 21 was having a specific causal effect on depressive symptoms, what we'd expect to see here is those lines fanning out, and the difference between the group who experienced and didn't experience IPVA getting bigger over time. But we don't see that at all here. These lines are completely parallel for both women and men. So to us, this suggests that this difference in depressive symptoms that we see for those exposed to IPVA is primarily being driven by things that have occurred before the IPVA in young adult relationships. So there's a vulnerability that's leading to an increase in depressive symptoms in adolescence, which persists into adulthood, and an increased vulnerability to the experience of IPVA in young adult relationships. Now, a couple of nuances to point out here. One is that although to make the assumptions of this analysis work, we've had to exclude those people who experienced IPVA in their intimate relationships before age 18. When we add them back in just to see what happens, those lines still look parallel. So we're not seeing any fanning out of those lines, even when that more exposed group are introduced back into the analysis. So that's one thing to say. A second caveat to the interpretation is to remember that here we're dealing with population averages. So this data suggests that on average, people's depressive symptoms don't worsen after the experience of IPVA in young adult relationships. That of course doesn't mean that that can't be true for particular individuals. This is just population level data. So I think next slide, Helen. I think I'm going to hand back to Christine to talk a bit more about the limitations of the data.
Thanks, Laura. Okay, so with any research, and I think particularly longitudinal research over 20 years, there's going to be some limitations, and probably the most significant one here is selection bias may have distorted the effect estimates. So around 1/3 of individuals still in the cohort at 21 answer the 21-year questionnaire. So therefore we have got quite a lot of participants who are no longer involved in the ALSPAC cohort study. And what we have looked at in relation to previous methodological work on the ALSPAC data set is that those participants, those children who were experiencing poorer socio-economic and health outcomes are much less likely to participate as we go along in relation to each of the timelines. So if we are therefore presuming that those with the worst IPVA experiences and the worst depressive experiences are less likely to participate, this would diminish the effect side on depression. And so the true general population estimates may in fact be larger than we have been able to capture from the cohort who participated in our questionnaire. But this is obviously a limitation that is inherent in many longitudinal studies where you have drop off, and you have drop off of probably those most hard to reach populations. So that's the caveat around the limitations. Thanks, Helen. So implications, I mean, I think that Laura has done a fantastic job of summarising the findings. So I'm just going to recap here. So looking at implications, we found that on average depressive scores at age 23 were 1 to 2 points higher for those who reported being victimised compared to those who did not. So that's sort of the general analysis did show that depression did increase. However, regardless of the causality, the findings indicate a likely mental health detriment in the years following IPV exposure in this young adult population. However, the higher levels of depressive symptoms reported by both women and men in our analysis who experienced IPVA victimisation are more likely to be associated with other things that have happened previously in their lives, other adverse health and social outcomes, rather than the IPVA itself. So consequently, our findings cast doubt over the causality of the effect of IPV on depressive symptoms. And this serves to highlight that IPVA is one of the series of challenges being managed by these young people. So in addition to supporting young adults who experience IPVA, services need to look at strategies for recognising and responding, and when safe, supporting young adults to leave these unhealthy relationships. But they also need to recognise that young adults would benefit from support in other areas of their lives and in their life history. So it's addressing the IPVA experiences, but also addressing the harm that they've experienced previous to that. I can see Nikki's lovely face just appeared, but I am nearly finished, Nikki. So thank you, Helen. So conclusion there, but I'm going to go into the next steps now. So we are going to look in more detail at the severity and multiple forms of IPVA victimisation and depression. And also we're working on a mixed methods paper, which will look at IPVA victimisation, but also look at wider forms of mental health. That's included in the ALSPAC data, but is also included in our in-depth and qualitative life course interviews. So thank you very much for listening. Laura, do you want to put your camera back on? I think, Helen, there's one more slide which just has the references there. And you can see that our paper is at the top there, and you can look at it even though it's under review at the moment. So if you have anything that you'd like to add to this, that would be handy, because Laura and I are responding to these comments at the moment. So any insights on what you think could be included in, particularly I think probably in the implications, would be great. So thank you very much.
Thanks, both of you. That's a really interesting paper, really fascinating. We don't have any questions in the Q&A at the moment, but if people want to raise them quickly, we can respond to them now. I mean, I wondered while you were talking whether, you had that very nice picture of all the different variables you were considering, and whether you were able to consider anything about young people's educational history, and whether the sort of level of attainment or anything on school attendance. I'm always very interested in.
We didn't adjust for anything like that. We do have data, we have linked data from the National Pupil Database on their educational attainment. And we have talked, Christine, haven't we, about doing some more detailed analyses about the IPVA, yes, and the education and stuff, but we haven't done that yet.
I mean, one of the papers we're working on, multiple papers, Laura, isn't there, going on all at once? It's quite difficult to remember what's what, but one of the papers we're working on is led by the qualitative aspect of the study and is looking at issues around isolation and loneliness. And one of the issues was there how lonely they felt in school. And that was the paper I think we're going to look at, educational attainment, with that linked data in, to look at what outcomes that might have in relation to what they're achieving. So, and of course we have it till they're 23, so we don't look at education alone, we can look at employment and so forth, can't we? So that will be exciting. There's so many possibilities with ALSPAC and the longitudinal data. It's difficult, isn't it, to decide which ones we keep for which analysis. So
yeah, I bet you have bullying in there too, don't you?
We've adjusted for bullying.
We've adjusted for bullying. We adjusted, didn't we? We looked at harm is what was our main criteria, I think, previous experience of harm and maltreatment and trauma for this analysis. But the second analysis, looking at wider mental health, I think will be interesting as well, to see what that association looks like. And one more shout out to Annie, who's at home with her baby, but you know, we are so grateful for her for doing all this work, including in her maternity leave, I might add, which we didn't ask her to do, but she's hugely committed, isn't she? So
okay, so we just have one comment from Karen saying, you know, what an interesting study this is, and also from Charlotte saying wealth of fascinating data, and we may have some time at the end, so if people can think of questions they'd like to put to Christine and Laura, they can come back then. But meanwhile, I'm going to introduce Liz. Liz, do you want to pop your camera on? Liz, are you there?
I am. I have put, just one second. Yes, there I am.
Ah, there you are. Hi.
Hi.
So I'm really pleased to introduce Liz Bates, who just joined us in the Connect Centre this summer as a reader. We're delighted to have her as part of the team, and she's got some really interesting research to bring to you. So I'll let her tell you all about it herself.
Thanks, Nikki, and hi, everyone. So let me just share my screen. Nikki, can you see that?
Yes, I can.
Great. Okay, hi everyone. So Nikki's ably introduced me, but I'm Liz Bates, and I've recently joined the Connect Centre. Very excited to be there and also here today talking to you all. What I want to cover today is to share some aspects of mental health, mental illness, taken from new police-led research, which I'm involved with, around domestic homicide and victim suicide. So I'm going to cover a few different elements, kind of aspects which I think are interesting in terms of the mental health dimensions here. And then at the end, I'd like to pose some questions to you all as a group about how we might interpret and what we should perhaps do about these findings. And that's very, I hope, very timely, but also very useful to us as we take the homicide project forward and think about further research in the coming months. So this is what I'm going to cover today. I'm going to briefly start by introducing the Domestic Homicides Project, where this data comes from, and then I'm going to cover these aspects of mental health as they relate to domestic homicide. So I'm going to talk about what we are calling suspected victim suicides following domestic abuse, and then I'm going to talk a bit about identified mental health issues amongst perpetrators of domestic homicide. I'm going to talk about suicide and suicidality of domestic homicide perpetrators. And then I'm going to wrap up by talking briefly about prior contacts of both victims and suspects of domestic homicides with agencies and services. Obviously, we all hope that our talks and our research are timely, but I think this is probably particularly so in the wake of some really quite high profile domestic homicides that have happened over the last weeks and months. And as I was writing this talk, I was particularly thinking about the really awful homicides in Plymouth recently, where there was, it kind of started, I would say, from an adult family homicide, and the man killed his mother, and there was quite a lot of discussion in the media around the
mental health and potential mental health and kind of known aspects of that of the perpetrator. So I think probably a timely topic to talk about. So just to start with introducing the Homicides Project, this is a project that was set up last year in 2020. So it was in response and was set up during the COVID-19 pandemic. It was established and is sponsored by the police. So that's the National Police Chiefs Council, the College of Policing. It's funded by the Home Office and it's managed and run through the Vulnerability Knowledge and Practice Programme, which is a kind of loosely police-led programme across the country. And I'm involved leading the research team for the project. The aims of the project, the reasons why it was set up are here. So the aim of the project was to understand better, to improve understanding of domestic homicide and suspected victim suicides during the pandemic. And in particular, to understand the true scale and nature of domestic homicide and suicides during the pandemic and lockdowns, comparing that to previous years where possible, to understand more kind of the typologies of perpetrators and to what extent they're already known to the police. And thirdly, to share rapid learning for police through this work about how police might identify or manage risks to prevent future deaths. I think it's probably just worth mentioning here as well that we took a wide definition for the project. So we took the statutory definition of domestic homicides that's used in domestic homicide reviews, but we also added and included cases where it appears that a person has died by suicide or where there was an unexplained death as a result of or following domestic abuse. So that is quite a wide definition. We also included the deaths of children of any age, so 0 to 18, again, broader than cases that would be considered for domestic homicide reviews. Just a word on methodology. So we set up a new method, data collection method, which is still ongoing, whereby every time there is a death that meets our definition, every police force in England and Wales completes a template form that we've developed and submits it to us as a central project team. So we're getting new data, we're triangulating those cases with other sources, so the Femicide Census, database held by Mankind Initiative, cases in the media, and we're also triangulating them with kind of official domestic homicide statistics from the Home Office and the ONS. But we're able to get a kind of live, quick time rolling picture of what's going on, and that's new. So the first thing I wanted to talk about, drawing on data from this project, and I think this is new and potentially quite groundbreaking data that we've collected, is counting and analysing what we say are suspected victim suicides. The reason we say they're suspected is because, as many of you will know, it is actually up to the coroner to decide and determine whether a death is a suicide or not. Police aren't able to do that, but police will certainly flag what they think are suspected suicides following domestic abuse to us. So this is the first project to systematically capture victim suicides in this way, and that's really important and is starting to give us a baseline that we hope to build on in future years. We found evidence of a sizable number of suspected victim suicides where there's a known history of domestic abuse. So 39 of our 215 deaths over a 12-month period, 18% of the total, were suspected victim suicides. We think, I think this is likely to be an underestimate. That is primarily because we are reliant on police identifying cases where there is a police known history of domestic abuse or where that history comes out in the investigation into the death. So I think it's probably reliable to assume this is an underestimate. 90% of these victims were female, 10% were male. They were mostly young, aged between about 25 and 44, and they were mostly white in a slightly higher proportion of white ethnicity compared to BAME ethnicities. One of the things I think is very interesting with this group of cases is that the abuse profile is actually extremely similar to the intimate partner homicide, IPH, in this talk. So we are looking at a set of cases with where the prior abuse prior to the suicide is mainly from an intimate partner, strongly characterised by coercive control, non-fatal strangulation, and attempts to separate or actual separation. Those were common risk factors in the history of these suicide cases. One thing I think we would note is that we did capture some what I would call COVID insights into the cases. So we asked police forces submitting forms to us to specify whether they thought COVID restrictions had had a particular impact on the death. And in the cases of the victim suicides, there were quite a few which did seem to identify that lockdown and COVID restrictions had played a part in the suicide. For instance, victims feeling more trapped, either trapped in with a suspect or perhaps a lack of other escape routes out of the abuse. One or two cases that corresponded with the perpetrator being released from prison or police custody as well. However, it's important to say that we haven't been able to comment on causation here, and there are plenty of other triggers and risk factors at play in these cases as well. And I think that points to a known and accepted limitation of our study, which is that we're capturing sort of fairly high level, mainly quantitative data, whereas that looking in more depth at how restrictions and other factors influence suicides is a really key part for domestic homicide reviews to play, and we must continue those discussions in conjunction with the third sector and colleagues like Advocacy After Fatal Domestic Abuse to really understand how mental health, lockdown and other factors might have influenced the suicide. The second dimension of mental health in these homicide data that I wanted to touch on today was about mental health issues identified in the history of the suspect. Perhaps worth noting, we didn't capture these, the mental health issues identified in the history of the victim in this project. We're primarily looking at capturing kind of risk factors and associated with the suspects. I think many of you will know and would tell me that mental health issues are not a causal factor. They don't cause domestic abuse. But previous work looking at domestic homicides has shown that, although that's true, where someone with mental ill health is known to be a perpetrator of domestic abuse, that obviously can increase the risk of harm to victims and sometimes to themselves, and we need to identify that and respond appropriately. So with that kind of a caveat around causality in mind, we see, and you can see from this chart on the slide, that mental health issues were the second most commonly identified risk factor in our cases. So 30% of cases identified a mental health issue as being a risk factor for the suspect in the case. I say it's the second most common because you can see that actually none of these risk factors were present in a huge proportion of cases, and that probably reflects the methodology we've used and the fact that these are risk factors known and recorded in the police history of the case. So I would say that the mental health issues being identified as the second most common factor for suspects shows that that is quite substantial and quite important. In terms of what those mental health issues were, we can see that 8% were identified as a psychotic disorder. Some of those were brief or temporary, others were longer term, and there was certainly a crossover with drug-induced psychosis. 12% were identified as depression or anxiety, and 11% were non-specified mental health issues. We'd obviously like to know more about all this. Again, this might not be quite the right data collection kind of method to understand that. We are looking to kind of map these factors against the wider domestic homicides. So underneath this headline, I want to really then note that we found that mental health issues identified in the history of the perpetrators were strongly associated with certain case types. And we, throughout our project, have categorised the homicides into adult family homicide, intimate partner homicide, victim suicide and child deaths in order to try and understand some of the contextual elements. So mental health issues were especially present in adult family homicide cases, just over half. And that was actually twice as likely or twice as common as the mental health issues identified in intimate partner homicide cases. This finding is actually supported by previous studies, a couple of which I've noted here. So research by the domestic abuse charity Standing Together, Montique 2019, found that a high proportion of adult family homicide suspects had diagnosed mental health disorders. Work by VAMHN and others in 2013 found that 34% of family homicide perpetrators had psychiatric symptoms at the time of the offence. So our findings are not new, they're kind of showing and confirming a pattern that's been seen already. We found quite a kind of co-occurrence with alcohol and drug misuse in these adult family homicide cases where there was mental health issues. And I've mentioned a possible link between drug-induced psychosis. There was a smaller but still sizable group of intimate partner homicide suspects, 29%, which had mental health issues identified in the history. Those mental health issues tended to be more around suppression and anxiety and some threats of suicide, less psychosis. So then the third element I wanted to touch on today was to talk about perpetrator suicide and suicidality. We collected and measured perpetrator suicides in the context of a domestic homicide. So we captured where somebody carried out a homicide and then took their own life. We haven't in this project captured where a perpetrator of domestic abuse took their own life, but not anyone else's. So with that in mind, in total, 9% of suspects in our project took their own life. As well, a different measure, 14% were recorded as previously known to the police for making threats of suicide. That characteristic was higher in the intimate partner cases, followed by the adult family homicide cases. There is kind of a wider increasing interest in perpetrator suicidality, and that is partly trying to identify it as a potential predictive factor for domestic homicide, but also researchers looking at whether that's indicative of vulnerability or need with the perpetrator themselves. And I think our data shows a more mixed picture in this regard, in that suspect suicide was present in a minority of cases, just 9%, but an important minority. And it was actually it varied according to the case context. I'm going to just go on to the next slide to talk about case context. So when we look at the different cases in which the perpetrator took their own life, we can see, I think, some quite different and distinct contexts. So most commonly, the perpetrator took their own life in the context of an intimate partner homicide. All of these perpetrators were male. But I think there's some quite interesting kind of sub-patterns here. The first I want to mention is perpetrator suicide amongst older couples. And we had quite a noticeable number of these cases. So this was where both partners were aged 65 or older. And there seemed to be what could be described as a mercy killing or suicide pact. And that was tended to be where the victim the victim was older, often unwell, physically or mentally, often potentially with a life-limiting condition. These couples were not usually previously known to police, so there are distinct and possibly different kind of context to that abuse, to that homicide. We want to look at this more because we think there's some quite a bit to investigate with this group of older couples. I say that some of them presented as possible mercy killings or suicide pacts, and that makes me uncomfortable. I think there is there's potentially the risk that some of those perpetrators presented it as that after the event. But we again need to kind of dive into a bit more of the detail of the case to investigate that further. And I think that again comes back to homicide reviews being really vital to understand that. The second group of intimate partner cases where the perpetrator took their own life was amongst younger couples. These were under age 55, and they were quite a different kind of previous risk profile to the older couples. Most of them had a record for previous high-risk domestic abuse. There was a history of threats to kill and attempts to separate. And then, as a sort of subset of this intimate partner group, there were a number of cases of what I've called familicide, where the perpetrator took the lives of their whole family, so partner, children and themselves. Interestingly, with this group, and they were a small group, none of the suspects there had a previous police record. So quite different, I think, to the younger couples listed above. And then as just a smaller group outside of that intimate partner context were child deaths. And here there were mostly mothers, so mothers who took the life of their child, who killed their child and then took their own life. And here I just want to note that there were 2 cases in that context where the mother took her own life, and 1 attempt to take her own life, and all 3 of those were known to be previous domestic abuse victims themselves. So then the last thing I just want to kind of highlight in today's talk is kind of whether and how the victim or the suspect was previously known to other agencies. We looked, of course, at how they were known to police, but this is a separate metric, which is whether they were known to other agencies other than police. So in just over half of cases, 56.7%, police recorded that the victim or the suspect was known to other agencies prior to the death taking place. This was higher in cases of suspected victim suicide and child deaths, and lower for intimate partner homicide and adult family homicide. Again, it varied by type. So victim suicide cases were more commonly known to mental health services, followed by adult family homicide and intimate partner homicide. And I think you can see this slide shows that the 3rd most common service that they were known to was mental health services. And I think this is interesting in the context of other research that's happened recently. So a paper by Marilia Kelcher and colleagues given at the recent European conference reviewed DHRs where the perpetrator was known to mental health services and found that only 10% were previously known to criminal justice agencies and only 10% to domestic violence specialist services. And that finding, that research also found a worrisome lack of risk assessment or asking about domestic violence by mental health services. Okay, so I think what I want to kind of convey there is that some domestic homicide perpetrators, maybe quite a few, are known to mental health services, but not to police. But you know, what warning and risk assessment and markers in terms of the domestic violence is being picked up by those mental health services. So I'm not quite sure how I'm doing for time because I can't see anyone else's video, but I assume I'm kind of coming to the end of my time. And really, I just wanted to sort of wrap up by posing some discussion points to the group, and I'd be very keen to hear inputs on this. So the first point that I'm sort of grappling with at the minute is how should we interpret perpetrator suicidality? I think I've emphasised it's important to not just see mental illness or suicidality as a cause of domestic abuse. There's strong evidence showing that perpetrator threats of suicide are often kind of in the context and part and parcel of coercive controlling behaviour, and that also can link quite strongly to attempts to separate by the victim of abuse. That said, this project, in common with existing research, clearly shows that perpetrator suicidality is a risk factor to victims, in that it is in a sort of substantial, albeit a minority, of the history of domestic homicide perpetrators. One thing I thought was interesting is that perpetrator suicidality is higher in the intimate partner cases, but mental health issues overall were identified more commonly in the adult family homicide cases. Does this possibly support the idea that suicide threats are being used as a tool of control, particularly with intimate partner abuse, and that perhaps looks different to other types of mental health issues identified? My second question is, what do we think are the implications of this for mental health services, and in particular for joint working between those services, police and other partners? And thirdly, I think, perhaps more philosophically, how can we appropriately discuss and place mental health dimensions without appearing to excuse or pathologise perpetrators? Okay, I'm going to stop there. I've just added on the end my references and also my contact details, but I might just leave the slide on discussion points up and perhaps invite some questions and thoughts on that.
Thanks so much, Liz. We have a number of questions on your talk, and so we'll deal with those while people are busy coming up with answers to your discussion points. So Catherine Mackridge asked if the police use medical records or assess if mental health is a factor using their own criteria or some sort of clinical diagnosis. This was in relation to risk factors for perpetrators.
Sorry, Nikki, I'm just trying to get out of the all screen so I can actually see the chat.
We can see and hear you. So the question is about really how police assess the presence of a mental health disorder.
Yes, so it's quite limited, I would say. So all of the information and data on which this study is this project is working is what's been submitted to us by police, and so that is reliant on what is known in the police record. It's why I've said throughout that I think a lot of these things, including the risk factors, the prevalence of certain risk factors, are likely to be under-identified, but that goes for all the risk factors. So proportionally, in relation to each other, they're probably potentially right. So no look at clinical records, no link up with those agencies in terms of our data collection. There may be, of course, in terms of reports that have gone into police and gone into that suspect's record, but that will be quite variable. We'd like to, and we are planning to do some work in the coming months to look at how police can link up much better with mental health services and other agencies, particularly around victim suicide. I'm not sure at the minute that extends to kind of assessments of perpetrator mental health. So it's a brilliant method, this project, but also a frustrating method because there's lots of in-depth things we'd like to get under the skin of, and it's not appropriate in this methodology. So hence wanting to link up with DHR reviews and other work as well.
Okay, thank you. Davina's made a couple of interesting comments. This is Davina James Hanman, who you probably know, who yes. Shares a lot of domestic homicide reviews. And she's made the comment that in her view, a lot of mental health issues only get as far, a lot of the perpetrators' mental health issues only get as far as primary care, where a perpetrator obliquely discloses abuse and says, they're finding it hard to think straight because of their relationship difficulties, and they get recorded as having a mental health issue when actually what they have is an inability to have an equal conversation with their partner or an entitlement issue. And she wonders if this is more prevalent in IPV cases rather than family violence.
Yeah, I mean, that's a big question and a really good one. I think that's probably right, but that's a personal reflection. I think the point about the differences between IPV and family violence is important, and I think, frustratingly, if you like, our project is only going to ever get to scratch the surface of that. But it's why I highlight where we know the difference between the mental health issues identified in those cases. So there are quite a few adult family homicides where there's clearly quite severe psychotic disorder with the suspect that we haven't seen in the intimate partner homicide cases, where it's more about self-reported depression and anxiety. Not to minimise that, but I think that can cover a wider range and a wider kind of scale of severity. What is captured in the police record, I think it will be variable, annoyingly. So I think it won't necessarily get at this question of exactly what's going on. I would suggest that these things will only be identified in the police record where there is some quite strong evidence of it existing, but I couldn't guarantee that. It's possible that there's been a previous interaction with the suspect where they've said themselves that they're feeling depressed, for example. So it is quite hard for us to unpick where that sits in this data alone, but my instinct would be probably with you, Davina.
Okay, and a question from Louise O'Leary, who asks about any differentiations regarding rural and urban locations.
Sorry, just reading down the chat. Yes, Louise, good question. We did capture in every submission whether the death took place in a rural or urban location. We also captured a bunch of other things, for example, the method of death and where it took place. By the way, I should have said we report on all of this and much more in the 12-month report that we've just published last month. The link was included on Nikki's initial slide, and we can send that round. So if you have other questions, do have a look at that. But to answer your question, Louise, we didn't actually find really any differences of note between rural and urban locations, which was quite surprising. I think we thought we might, but in terms of almost all of the factors we've looked at, we didn't see any noticeable differences. So we haven't really got a lot to say about that. It may just be that this study doesn't adequately kind of get under the skin of those dimensions, but we did capture it. Nikki, is it worth my going back to the other question that Davina's posed in the chat?
Right, yes, please. I've also got some other questions.
Okay.
But why don't you respond to Davina's other question if you've picked that up? Because that was an interesting one, wasn't it, about the two different systems?
Yes, so Davina says, I find there's a huge gap in understanding of risk between mental health services and the CJS, and also a big gulf in culture. And she says, you know, from her experience in DHR panel meetings, it's as if the two systems are speaking wholly different languages. Again, it's not something that we got to observe in this study, but one of the things that kind of made us question and a little uncomfortable in our analysis was that we felt, particularly with the adult family homicide cases, there were clear cases where the suspect was really mentally unwell and they were being released to the care or to the sort of the default situation of the care of their family, often parents or grandparents. And as far as we could see, and I caveat that heavily with we don't see everything that's happened, there wasn't any sort of strong risk assessment taking place about whether that was appropriate. So it's one of the reasons why in our report we have said that we've recommended actually to the College of Policing that they need to review domestic abuse risk assessment, whether it works adequately for these adult family homicide cases. We've only really been able to make recommendations to police bodies, as that's the way we're set up in the project. But I think I agree, really, there's a lot to be done here between mental health services and the justice system, in particular the police, in terms of identifying and managing that risk. And I don't have the answers, so we're very happy to have that conversation or to hear from others if they have suggestions around that. I think I would say that the police are very open to this, and they're very aware themselves that they cannot be the only agency to manage all this. So it really does require that kind of multi-agency response, but they're definitely open to suggestions.
Okay, thank you. I wanted to pick up a couple of points which were in the chat. One from Davina saying people should be clear that domestic homicide reviews are undertaken on suicides too. And then Sonia talking about the older women. And I was very interested in this, and this made me wonder whether, you know, where there are cases of suicide pacts in older people, whether, you know, the police should really be looking for a history of domestic abuse in some of these cases, and whether so-called suicide pacts are actually sort of coerced joint suicide. Sonia makes the point that their services had an increase in older women seeking support for domestic violence, many of whom only now realise they've been controlled and abused throughout the marriage. So, you know, I guess that's heartening in a way, because it means that perceptions and awareness are changing in among older people as well as younger people.
Yes, so to take that in turn, very important point that domestic homicide reviews are and should be conducted for victim suicides where there is a history of domestic abuse. I believe that is in the Home Office statutory guidance on DHRs. We actually looked at that as part of this project. We asked in every case whether the death had been submitted for a domestic homicide review, whether it had been accepted, and if not, whether it had been referred for an alternative review. Interestingly, in our first 12 months data, the suspected victim suicides were referred at a similar rate to the domestic homicide, and they were accepted at a similar rate. I think we're a bit surprised by that because feedback from sector colleagues, researchers and others would suggest that they weren't perhaps being referred and accepted at the same rate. That said, we kind of felt in our it's certainly in a number of the cases that we reviewed that they perhaps should have been referred, the suicide cases should have been referred and weren't. So one of our recommendations to the police from this 12-month report has been to update the authorised professional practice for police on victim suicide to make sure it speaks more tightly to the APP on domestic abuse, and to make clear, and this has happened already, to all forces that that suicides can be and ought to be considered for domestic homicide reviews. So I think more work to be done there, but some interesting figures have come out. The question on older women, well, older couples, but it is, I think, almost exclusively older women. Really interesting. We've actually got a paper under submission at the minute which looks at this in more detail. We found, I would say, a sizable number of older victims in the intimate partner homicides, but also in the adult family homicides. So that latter group has been highlighted in other research in the last few years. So that's quite often parents or grandparents, predominantly women, being killed by sons or grandsons, occasionally daughters and granddaughters. And then the older couples in the intimate partner homicide, really interesting. Again, frustrating in a way that we haven't enough detail, or we can't go into that level of detail in this project. And I think it is for those DHRs really to look at this, and I'm sure they do. But I think there's, it's very difficult, and it's very hard for police turning up on the scene to be able to distinguish whether this is sort of genuinely a mercy killing or a suicide pact, or whether it is actually a kind of ongoing domestic abuse where the perpetrators presented it as that. And I think it's, one thing I would say is that police and other agencies need to be really alert to the fact it could be one or other of those, and not just listen to what the perpetrator is, the story that they're telling, and certainly to kind of not just to kind of resist the assumption that because someone's old, and we're looking at quite a number of cases where victim and suspect were in their 70s or older, and where they had life-limiting conditions, so dementia, cancer, these kinds of things. And I think there's quite a lot more to be done there. Yeah, I'll leave that there.
Yeah, it's really, really interesting question, isn't it? Okay, we're at 1 o'clock. We should finish. I want to finish with a comment from Shelley, who thanks you for your excellent presentation and says we need to establish routine inquiry about domestic abuse in mental health services where relationship issues are too often documented. We need an improvement in mental health services in professional curiosity and a stance of curious concern, and DVA training needs to be mandatory if staff are to be supported to practice at the NICE quality standards. So I think that's a really important message for mental health services, isn't it? I'd like to finish by thanking all our presenters today. I think 3 sort of contrasting but really interesting papers. I think we've got a couple of final slides to put up. Our next Connect Centre seminar is on Wednesday, the 3rd of November at 4 o'clock. And Liz will be talking again about domestic homicides. And anyone who would like to hear more about that is very welcome to join us, and can contact us through the Connect Centre email. Also, the Violence, Abuse and Mental Health Network has their next seminar on the 6th of October from 12 to 1:30, and that's going to be on violence, technology and mental health. So loads of events for us all to be meeting again at. It's been great to have so many people here today. We've had people from across the UK. We've had international people attending the event from really diverse settings. I noticed we had a play worker, we had someone from probation, as well as people from mental health and domestic abuse services. So it's been a really interesting audience, and you know, we just wish we were actually able to sort of engage a bit more fully with you all, but it's been lovely having you all here today. So thanks for your engagement and attention, and thanks again to all our speakers, and hope to see you at future Connect Centre as well as Violence, Abuse and Mental Health Network events. Bye.
Oh.